Hi, I'm going to go ahead and get started, and then if people are coming back from the break, that's fine. Just a quick introduction. My name's Kate Debiec, and I am a pediatric and adolescent gynecologist, which means that I did an OBGYN residency and then a fellowship in pediatric and adolescent gynecology. I spend most of my time at Seattle Children's Hospital, and most of my patients are adolescents. We do regular gynecologic care, but just for people who are teenagers. So I'll get started. The things I wanted to talk about today were the timing of a reproductive health visit, the structure of a visit, menstrual periods, contraceptive options, and having conversations with teens about reproductive health care. Obviously, because I'm a gynecologist, this is going to be more focused on daughters and female relatives, and but hopefully a couple of points of interest if you have boys as well. So in terms of the timing of the first gynecologic visit, there are a couple of different questions that people ask. When should I take my daughter to the gynecologist for the first time? Sometimes people wonder, when do they need their first pap smear? Should they go when they're sexually active? Should they go before they're sexually active? What age do they need a pap smear if they're sexually active, if they're not sexually active? So in general, the recommendation for the first pap smear, which is a test for cervical cancer, is at age 21. That's regardless of sexual activity. So if they became sexually active at 14, 18, are still not yet sexually active, the recommendation is for screening at age 21. The recommendation is a little bit different for girls who are immunosuppressed, like women who have HIV, or if they've had a transplant of some kind. But otherwise, for most healthy individuals, 21 is the start age. The American College of OBGYNs, we call that ACOG, recommends the initial reproductive health visit at age 13 to 15. So people wonder what's happening at that visit if they don't need pap smears until they're 21. So in general, we're not doing pelvic exams. We're not doing internal examination. What we're doing is we're establishing a relationship to build trust and rapport, and to build a place that's separate from their pediatrician sometimes. And we talk about all aspects of healthy behavior, not just reproductive health care, but how to take care of themselves. Sometimes we are doing some of the wellness screening and some of the assessment for substance abuse. We also will widen or narrow the scope of the visit depending on what the person's concern is. So if someone is perfectly healthy, we just go over what it is we do, what services we can offer. If they have no questions, we're just it's sort of a meet and greet. But if they have a specific question about birth control, about their periods, then we may focus down on that. And we also are going to take into consideration someone's individual developmental needs, medical history, and also their physical needs in terms of the things that we counsel about. A number of the young women that we see at Seattle Children's have other health conditions or developmental delays, and so those visits are going to look a lot different than someone who is neurotypical or typically developing. In general, we will do a heart and lung exam, but we don't necessarily do a breast exam. Sometimes we do, and sometimes we'll do an external pelvic examination depending on what their concern is. So if they're there for a breast concern, then we're probably going to do a breast exam. If they're there for a menstrual exam or menstrual issue, we may do an external exam or may not. The structure of the visit sort of takes into consideration that you have the physician or provider, you have the teen themselves, and sometimes they've brought a friend with them, and then the family. And usually what we do, this is just kind of a general guideline, and I'll sort of talk through the way we do it or kind of role play how I do it, which is that I enter the room and I introduce myself and I tell people what they can expect from the visit, because a lot of times a teen is nervous coming to me because they have no idea what's going to happen to them, and sometimes the parents haven't been able to allay those fears because they don't know what's going to happen either. And I do, at least in my practice, allow some of the pathway of the visit to be dictated by the teen and what they're comfortable with. But in general, what I do, particularly for older adolescents, not necessarily for younger ones, after the initial introduction, I say that we'll all talk as a group with the teen, parent, and myself. At some point, I will have the parent step out to the waiting room so the teen and I can talk. And then usually what I'll do is I go get the parent, and as I'm walking them back to the room, I allow them some time to ask me questions. Obviously, the questions and answers that I give are going to be dependent on the content of what my conversation has been with the teen, and I can't give the parents confidential information if the teen has revealed things to me necessarily. And then at some point in the exam or during the visit, we may or may not do an exam, and I usually leave it up to the teen to decide if their parent is present for that or not. We do not do any intimate exams with just the provider and the teen. There's always either a medical assistant or a nurse there, but some teens feel more comfortable with their parents outside of the room for more intimate exams, and some people feel more comfortable with their parents inside the room. And I try not to put the teen on the spot and ask them when their parents are there, if they want their parents present for an exam. And then I always tell the parents we're going to come back together as a group and have a big discussion. In terms of specific to gynecologic and reproductive history, some of the things that we often ask are the age of menarche, which means the age of first periods, what the teen's cycle interval is, so from the first day of a period to the next day of, or from the first day to the first day, what the length in between is. So are they having 28-day cycles, 31-day cycles, 3 months in between? We ask how long they have bleeding for, what their flow is like, what kind of pain they have, if they've used any hormones or birth control in the past, and if they have been sexually active. We talk about things like numbers of partners, when their last sexual encounter was, what kind of birth control they're using, if they use condoms, and whether or not they've had the HPV vaccine. Just to go over what is sort of considered normal and not normal, because I think sometimes people's perception of what is normal for a menstrual period is based on what happened to them. And so sometimes people will perpetuate a abnormality. So people might say, oh, don't worry that you're going through like 15 pads a day. That's just what it was like for me. But that's not normal. Or they'll say, oh, I had periods every 3 months too. That's normal. But it's not normal. So sometimes what we're doing is we're sort of doing a little bit of myth busting about what it should be expected from menstrual periods. So on average, people will have their first menstrual period between the ages of 11 and 14, some younger, some older. And on average in the US, the average age of the first period is about 12 and a half. Cycles can vary from every 21 days. Again, that's the start of one to the start of the next. So if people are having 21-day cycles and bleeding for 7 days, it can seem like they only have 2 weeks off, but that's still technically normal. So anywhere between every 21 to 45 days, menstrual flow length should be 7 days or less, and less than 6 pads or tampons per day. We consider it important to evaluate people's periods, not just for the effect that the period is having on them, but sometimes abnormal menstrual periods in any of those realms can mean that there's some underlying thing that's not right and that needs evaluation and workup. So some of the things that we evaluate people for, if people had breast development but they still haven't had a period 3 years later, that's not considered normal, and we usually want to do an evaluation for that. If they have excess body hair and haven't started by age 14, if they have any signs of an eating disorder, low weight, underweight, and haven't started a period by age 14. For any reason whatsoever, if there have been no periods by age 15, we usually need to initiate a conversation and a workup. If they're occurring more frequently than every 21 days or less often than every 45 days, and particularly if they're occurring more than 90 days apart. That cycle length interval represents only 5% of people or less will have that kind of cycle interval and is not considered a normal finding. Periods are lasting more than 7 days, if they're having lots of heavy bleeding, which can be demonstrated by pad changes, or if there's a family history of a bleeding disorder. Moving on to birth control options. So this is always like a tricky conversation because our gynecologic toolkit, when we open it up, it has the same things in it regardless of why people are coming to see us. So if people are coming to see us for birth control, for pregnancy prevention, or family planning purposes, we've got the same things in the toolkit. If they're coming to us because their periods are heavy or because their periods are painful, debilitatingly painful, we've got the same things in the toolkit. And so I always feel like birth control should have should be rebranded as period control. But the options that we have for period control, there are combined hormonal options, which include the pill, patch, and ring. There are progestin-only options, which include the IUD, the arm implant, progestin-only pills, and Depo-Provera. And for birth control, though not period control, there are non-hormonal options, including a copper IUD. I usually will talk about these options in those sort of three categories because the side effects tend to be pretty similar for the combined hormonal options. So side effects of the pill are similar to those of the patch or similar to those of the ring, and the risks are the same. And the reasons that someone can't use one of those are going to be the same. So some examples of reasons why people can't use the pill, the regular pill: migraine headaches with aura. So if a young woman has migraine headaches with vision changes, then she is not supposed to use the birth control pill. High blood pressure, liver disease, or increased risks of blood clots, because estrogen, which is in the combined hormonal pill, can increase people's risk of blood clots. In terms of side effects, early start side effects tend to be kind of in these two categories. So headaches, dizziness, and sort of nausea, GI side effects tend to be the most common. A lot of times people will ask about weight gain. Weight gain is not usually a tremendous concern for the combined hormonal options, but anybody can gain weight on any of the methods. It is usually not a very high amount. The progestin-only options, the reason the first two have stars is because they are the most effective birth controls. So the hormonal IUDs, there are several on the market right now. Their names are Mirena, Liletta, Kyleena, and Skyla. And they have just different doses of the same medicine in them. That's a T-shaped device that's placed in the uterus, usually in an office procedure. And the arm implant is a thin rod about the size of a matchstick that's placed in the skin under the arm. Both of those can be used to control periods. So if your daughter goes to a school health clinic and comes home with one, it's not necessarily some secret way of like getting birth control. Sometimes it really is for period control. Particularly the hormonal IUDs, they offer excellent menstrual suppression. So they stop periods really well or slow them down really well for people who have heavier painful periods. Progestin-only pills, otherwise known as the mini pill, are pills that only have one hormone. They don't have that estrogen hormone, so they're safe for people to take if they have migraine with aura or high blood pressure or certain medications. And then Depo-Provera is an injection. We don't actually use a whole lot of the copper IUDs at Seattle Children's because most people don't just want birth control. They also want something that will benefit their periods, which typically the copper IUD does not. It typically will make people's periods a little bit heavier and longer and crampier, which is usually not a great selling point. So we probably put in about one for every 50 to 100 Mirena or hormonal IUDs that we put in. These are pictures of the various options. So up in the left corner, the copper IUD, it's literally a plastic T-shaped device that's wrapped in copper wire. The Mirena is in the palm of that person's hand. It's a small T-shaped device. Birth control pills, the ring, the patch on that young woman's abdomen. The pills that are in multiple packets are extended cycling pills, so sometimes people can take pills where they're taking them and skipping their periods. The vaginal ring, Depo-Provera injections, and then this is the size of the rod for the Nexplanon. And then Plan B, so Plan B is emergency contraception. So if someone, for instance, has intercourse, forgets to wear a condom, condom breaks, this is a good backup. I generally tell people that happy to give prescriptions for Plan B, but they need to have a Plan A too. So Plan B is not a Plan A. That cannot be their primary contraception. And then talking with teens, so this is going to be my last slide, so I was able to kind of go through things quickly, but I'd be happy to take questions as well. Conversations with your teens. You want to talk with kids about more than just the birds and the bees. Sometimes it's not just necessarily about the parts and the facts. Sometimes it's important to talk about the relationship aspects of intimacy. And not sometimes, I think always, it's important to involve that in the conversation. There are I think really good reasons why it can be uncomfortable for some people to talk about sex, sexuality, and reproductive health with their children because of their own personal histories. And so if that's the case, the kids are still going to be having questions and wanting to know things. And I think, unfortunately, we can't always depend on that information to come from the schools. So if it's necessary and if you don't feel comfortable having those kinds of conversations with your kids, you can take them to the doctor and kind of initiate some of those conversations. They're also they're generally geared towards younger kids, but at Seattle Children's they have the heart-to-heart talks, one-on-one guide for talking about puberty. It's geared more for 10 to 12-year-olds, and they do them at Overlake and Seattle Children's. I don't know if they have one south. I know Overlake and Seattle Children's.
They actually do it here.
Okay. So those are phenomenal. They're the seminar that I went to, or the version I went to at Children's was 2 weeknights for 2 hours. So it was 2 Tuesday nights, I think. And the initial one is about biology, anatomy, and having conversations. And then the second one was about sort of humanizing puberty and a pubertal experience. It's usually, the suggestion is that a child is taken with a same sex, same gender adult, whether parent or trusted relative, and they get opportunities to ask questions, and it really sort of normalizes puberty and normalizes some of the conversations. I think having open communication is important. So again, not just talking about sex, but having ongoing quick talks, like in the car, and involving conversations about relationship, trust, and consent, not just how you prevent a pregnancy or how you prevent STDs, but how you have a safe and healthy relationship with another person.